to stay awake. So I am a pediatric palliative care physician, and to address the elephant in the room, pediatric palliative care, yes, it is emotionally challenging, but it is about more than just death and dying. That being said, I'm going to talk about a few challenging cases where patients die. And as a disclaimer, I just wanted to ask if we have any bereaved parents or siblings in the room. Okay. I just like to ask that to make sure, because some of these things can be emotionally challenging to talk about and hear about, particularly if you have a close personal relationship like that. All right. The requisite learning objectives slide. I'm going to talk about the holistic approach of palliative care as it relates to palliative medicine, and the importance of humanities in palliative care. And the third one I just threw up there because I don't really like objective slides, and I think it's a good thing to do in general. So I hope that you all go out of here today and appreciate what is left of what appears to be a beautiful day. This piece here is a famous sculpture. To start out with, I don't want you to think about what it is, the story behind it, the history of the piece, anything like that. We'll get to that in a minute. What I'd like to start out with is just tell me, what do you see? And then tell me what makes you say that. So what do you see? Anyone? Yes?
So, the mom was kind of mistreated and gestured that her child was kind of slipping off her lap.
Okay.
And she can't really catch me with her arms were extended and she was trying to.
Very good. What else do you see?
Well, what always impressed me about this sculpture is that the child is always the child even when he's an adult. To me, that is always very touching about this sculpture.
Absolutely. Absolutely. What else do you see?
A lot of vulnerability, like in terms of like skin exposure, the position that women are flying in.
Yeah. What else? There are no wrong answers. Yes?
My first thought was Mary and Jesus. I don't know if that's what this sculpture is, but that was what I saw first, probably because of my upbringing.
Very good. What else? What do you see? Or what do you feel?
It kind of strikes me that it looks like her skin's dying in her arms, but her face is not super emotional. Maybe it's a little somber, but not necessarily like devastated.
Yeah. Okay.
Yeah, I was going to say, I see or feel disappointment more than devastation.
Okay. Yes?
I think because of those two things, I saw this more like the last glimmer of hope kind of maybe was one last thing.
Okay.
I didn't immediately see it as a mother-son relationship, actually. I thought that she was somehow divine, like a angel or saint or something, and then accepted someone with it.
Okay. Very good. What else? You see? This is great. Thank you. So this is the Pietà. It's a piece that was sculpted by Michelangelo Buonarroti, not the Ninja Turtle, although to be completely honest, the Ninja Turtles were my introduction to the masters, Raphael, Donatello, Leonardo, and Michelangelo. But the Pietà was commissioned just 6 years after Columbus arrived in the Dominican Republic. And just to put that in historical context for you, that's a long time ago, but that's when this was made. It was sculpted out of fine Carrara Italian marble, and it is currently housed in St. Peter's Basilica in Vatican City. It's also, interestingly, the only work that Michelangelo ever signed. I picked this piece for a couple reasons. One is the stories that it's going to relate to in a moment, but another is because I actually used this piece and did this exercise with some of my fellows in palliative medicine over the last couple of years. And it's one of the pieces that tends to provoke a lot of conversation, and there's a lot of things to see in it. So, the Pietà is in fact Mary holding Jesus after the crucifixion on Golgotha, and Mary is depicted as a very young, chaste Mary, and Jesus is depicted at the age that he was approximately at the time of the crucifixion. There's a very detailed story if you'd like to learn more about it. Big book about it. I recommend you check it out. So I'm going to tell you a few stories about what I see in the Pietà. And like I said, some of these can be emotional. And each story that I'm going to tell you, I hope to illustrate to you how pediatric palliative care is a holistic way to practice medicine through teamwork. We've heard a lot today about the role of the doctor-patient relationship. I would like to expand that to consider the clinician-patient relationship. So any field that you may go into that you're providing patient care or interacting with someone who's in the patient role, all the things that we've been talking about, that we've heard about today, are going to apply. It's not restricted just to the physician-patient relationship. So the first story that I'd like to share with you is about Billy. Billy was 19 months old, and he was a little boy with medulloblastoma, which is a type of brain tumor. I went to go meet Billy and his family at their home, and he was toddling around, as 19-month-olds do, and he, saw new friends that came into the home, and so he brought over all of his toys and wanted to show us everything, and wanted to sit and read with us and so on. But Billy was dying of his cancer. It had already kind of gotten past the point that any cure-directed treatment could address. And so one of the reasons that I was there was to assess him for symptom management needs and what I anticipated he might need from a physician, pharmacological medicine type of perspective. A couple weeks later, Mother's Day, about 12:30 in the morning, I got a call from my hospice nurse, and Terry said, "Dr. Dan, Billy's not doing too well. I think we need to make some adjustments of medications." And so we did. And we controlled his seizures. And Terry was there and walked the family through the adjustments that we were making. And when Billy started having trouble breathing, Terry was there and we talked and we figured out how to adjust his medications. And when Billy died, Terry was there, and she helped the family through the end of life and grieving, the beginning of grieving process. And it's something that I wanted to highlight, that the nurse, the relationship between a nurse and the patient is a fundamentally different relationship, I think, than one that physicians and patients are able to know. And if you've ever shadowed or spent any time on an inpatient unit, particularly in oncology, I've noticed the nurses develop amazing relationships with their patients. And it's really, truly special. And they're able to extend the way that we provide care in pediatric palliative care to more than just what I'm able to do with symptom management and things like that. Mother's Day was a rough day this year. A few hours later, I got a call from the ICU about Jason. I want to back up a little bit and tell you some of the story about Jason and his family. Jason was a 14-year-old. He had leukemia. He had gotten 2 bone marrow transplants to try and cure his leukemia. Unfortunately, during the course of all of that treatment, as sometimes happens when you get multiple bone marrow transplants, other organs were damaged. And so his liver and his kidneys were really sick. And his lungs were really sick. And he had a couple infections that were not able to be treated, despite maximal treatment with multiple antibiotics, antifungal medicines, antiviral medicines. And at one point, so he was in the ICU because he had pneumonia. He needed to be intubated to help support his lungs, and he needed to have dialysis to help support his kidneys. So he's in this really bad position. He's in the ICU, but he's still able to be awake. And we sat down with the family, let his parents know what was going on, and they said, Jason has a 17-year-old brother, and he has a 10-year-old brother. And I'm not sure how we're going to be able to tell them that their brother is not going to survive. And so what we recommended is that we said, you know what? Our child life specialists here are fantastic. They are specifically trained in dealing with sibling bereavement and speaking with children at their own individual developmental level. Because children at different ages will have different understandings of things like death and dying. So Stephanie came by, and it turns out that all 3 brothers actually like doing arts and crafts. They all like to draw things. And so Stephanie got all the markers, all the paints, sheets of huge paper, and for an entire morning and afternoon into the evening, Jason and his brothers, and even his parents got in on it. They did posters and pictures and handprints, and even got little clay beads made with fingerprints on it that they could all have. About a week later, which brings us back to Mother's Day, Jason had gotten sicker, even more than he had been before, so much so that he had to be sedated so that he couldn't be awake anymore, he couldn't interact. He actually stopped being able to interact a day or 2 after Stephanie helped the family make all those things. And at that time, Jason's parents decided that what was most important to them was the quality of his life rather than the quantity of his life. And they made the decision to take Jason off the ventilator and let him die peacefully. And so without the help of Stephanie, we would not have been able to coordinate Jason dying in his mother's arms, peacefully, surrounded by pictures that he and his brothers had drawn together. And it was a very poignant reminder of how much the child life specialists bring to the table at helping us provide high quality, interdisciplinary palliative care. So I know these are heavy to hear, they're heavy to kind of relive, but just one more that I want to talk about, and then we'll switch on to some lighter topics. So Christopher was 11 years old. He had metastatic bone cancer, which is very, very painful. And he had to be on a home morphine infusion all the time, 24 hours a day, because of how severe the pain was from his metastatic illness. Jason lived Christopher lived with just his mom, who was single, and his mom had a history of drug abuse. Christopher came in a few times, and he had infections in his bloodstream, and his pain would be worse. And none of us really wanted to, think about the possibilities of what might be happening, but, it happens once, it's occurred twice, coincidence, 3 times the trend, and so we needed to investigate what was going on. And so we asked our social worker, Jen, to come in, talk with Mom, talk with Christopher. Turns out that our fears were confirmed, that despite our best attempts to manage Christopher's pain and give him the best medical care possible, that some of his pain medication was being diverted and abused. Jen was able to coordinate hooking up Christopher's mom with some counseling and getting her the treatment that she needed. And she was also instrumental in coordinating the placement of Christopher into his grandfather's care, to make sure that he would continue to be cared for safely and have his meet all of his clinic appointments, make sure that his pain was adequately controlled, things like that. Again, Mother's Day was a bad day. I don't know why all these guys decided that was the day, but he came in that afternoon with a really bad blood infection. And it was so bad, in fact, that Christopher needed CPR 3 times in the ICU. When I got in there, I sat down and was talking with his grandfather. We were at the foot of his bed, and his grandfather asked, "I know what's going on, but can you keep him alive until his mom gets here?" I called and asked for her to come in. And so we said that we would try, but that he was very, very sick. And unfortunately, Christopher died about 10 minutes before his mom was able to arrive that night. But Christopher got a lot more time, and he got a lot more care than may have been possible if we had not had our social worker to help provide the holistic care and address the social circumstances that were impacting and preventing the optimal care of Christopher. Deep breath. Okay, those stories are over. Thank you for bearing with me through them. I know they can be tough to listen to. But those are the stories that I think about when I look at Michelangelo's Pietà. I see the grief, the anguish, the blank disbelief on the face of a mother who's holding someone who means the absolute world to her. So why would anybody do this for me? This sounds terrible, doesn't it? I hate definition slides, and so I'm going to slap myself on the wrist for putting one in here. But I just wanted to include it because I thought that, honestly, it is able to illustrate what I see as the relationship between pediatric palliative care and not just the talk, or not just the theme of the symposium today, but medical humanities in general. We talk about caring for patients, and that cure, or the concern, the attention that we give, and I think it's why a lot of us go into medicine is we care for people. We have that empathy. We want to help people. Palliative medicine, rather than curative medicine, palliare is Latin for cloak, or to cloak. When no cure is possible, care is still possible. And so that's one of the reasons that I went into practicing pediatric palliative care. Holistic is, like we've talked about, treating the whole person in the context of their own life rather than just seeing someone as a list of ICD-9 or ICD-10 codes or just the collection of data sitting in the bed while you're staring at a computer screen. And the interdisciplinary aspect of palliative care is one that enables us to practice it well and really provide that holistic care when patients still need care and cure is not possible. So I apologize, this is supposed to say the palliators, not the vendors, but I'm not very good with technology either. So anyway, I want you to meet the team. We have medical representation on the team, and my sort of specialty as a physician member of the team is to write the orders for drugs most of the time. Knowing the pharmacology of symptom management and complex illness and things like that is a very important part of my role as a palliative care physician. And in addition to advanced practice nurses, we also have a regular nurse on our team. And as I talked about before with the story of Billy, the relationship between a nurse and a patient is a different one than what physician and patients often share. And so a nurse is going to get a different lens, is going to look through a different lens when they're looking at that relationship with the patient. They're going to provide a different kind of information and a different kind of care. Same with the social worker, as we talked about with Christopher. It's a different lens, it's a different kind of care, but it's just as important in treating the whole person. Chaplain, addressing spiritual needs of the patient and the family. Child life specialist, bringing the siblings into the mix, or even, the patient themselves. As was just mentioned before, how do you tell a patient who's 14 years old that they are going to lose a limb because of their cancer? Having someone who is versed in the developmental processing of kids at different ages is very helpful in being able to do that. And then a psychologist is an additional excellent member of the team to be able to help with the processing of what can be very difficult news, particularly in my field. So I started out talking a little bit about pediatric palliative care. I'm just going to expand a little bit more on that now that you can see the different roles and the different team members that we have. Despite the 3 stories that I just shared with you, not all of our patients die. And despite the 3 stories that I just shared with you, not all of our patients have cancer. Only about 20 to 25% of them have cancer. There's a variety of other diagnoses. But about 50,000 children in the United States die every year. And there's a whole lot more kids who don't die but have complex or very severe illness. And who really deserve care that addresses them in the context of their own life and their disease as it relates to their family and them as an individual. We try to emphasize quality of life in palliative care. We talk about advanced care planning, and we talk about just because we can't do something in medicine, should we do that? Is that really the best thing for you, for your family? And thinking through those questions with families, hopefully before a crisis time, before an impending intubation in the ICU, is very helpful. And families seem to really appreciate having a team who sits down and asks them these questions. Because a lot of times they're thinking these things anyway, and don't necessarily know how to give voice to the worries, the concerns, and the hopes that they have. So I'm going to wrap up. How are we doing on time? Good? Okay. like I said, I'm bad with whole technology things. It's supposed to be your rice menu logo thing, but it didn't work out. Anyway, to wrap up, everyone deals with grief and illness and death and dying in their own individual way. But providing holistic pediatric palliative care requires a team that can help support a family no matter what that grief or what that difficulty looks like, no matter what that suffering looks like. And you don't have to go to medical school to be able to provide empathic care for someone. As I mentioned before, all of the members of our interdisciplinary team are able to provide excellent holistic care, looking through the lens that their specialty trains them in. And then going back to the Pietà and tying it back to the medical humanities, when I look at what is a large, heavy, cold piece of marble that has been expertly crafted, it evokes an empathic response in me. I am able to see the grief, see the disbelief there, and it's remarkable that a piece of stone, or a poem, or a song, or a painting can evoke that responsiveness. But sometimes there are emotions, there are things that we feel that will transcend just the ability to speak about them in words. And I think that's one of the wonderful things about the humanities as they relate to medicine. If I were going to just leave you with one piece of advice, if you're going to be a clinician of any kind, I would say when you go in to meet a patient, whether it is in an ER bay, whether you're going into an ICU room, whether you're going into a clinic office visit, how you doing? I'm Dan. I'm your doctor today, or I'm whatever clinician role you're in. Sit down so you're on an even space with them, and then how can I help you? And see where that takes you. So, thank you very much. I appreciate your attention. Are there any questions or comments? Yes.
Well, first, yeah, you had that, list of all the individuals on the team, and I was curious, what sort of mechanisms do you have to integrate that team? Do you have regular meetings? Because you talk about how they bring different perspectives. How do you learn to speak each other's languages so you are getting an integrated service?
Excellent question. We meet every week for at least an hour or two to discuss all of the patients that we're currently following from the perspective of each of those different specialties. And we sit and go through it so that so that all members of the team can have the most comprehensive view through all the different lenses as possible to be able to provide the best kind of support for families, no matter what that may look like. Yes?
How do you coordinate the healthcare decisions with teenagers that you're working with who are not yet 18 and are under their parents' care but are old enough to make decisions?
Great question. Where are you getting at?
I just wonder who you have to report to, the patient or the parent in that case.
Who might you think?
I don't know, that's what I'm asking.
It's a very good question, and it's one that comes up in medical ethics quite regularly. And there's something that we refer to in bioethics as the rule of sevens. Below age 7, basically it's just the parents. Between 7 and 14, it's a mix of the parents and the child's perspective, and over 14 tend to need to give a little bit more credence to what the patient themselves is thinking, feeling, considering. But at the end of the day, ultimately, it is the parents who have legal decision-making capacity for the patient until they're 18. So if there are differences, we try to sit down with them and see if we can get everyone on the same page and help understand one another's position. Great question. Yes?
For, I don't know if this would apply specifically to you or, I'm just in general, like doctors who work with patients at the end of their life, like children, is that a common thing for like, especially the ones that work closely with them, like for a long period of time? Is it common for you to like be invited to funeral?
It's not uncommon.
You go.
I've been to a couple. Yep. And I think that it is a very personal and very individual, situationally dependent decision as to whether or not you feel it's appropriate to go.
How about burnout?
Very real concern. Very emotionally challenging work, and one of the ways that we address that is recognizing burnout and looking for it in all of our colleagues. So when we have our interdisciplinary team meetings and we're sitting with, chaplain, psychologist, social work, nurse, physician, everyone there, and even just in the day-to-day things, if someone looks like they're getting a little crispy, a little burnt around the edges, we will actually, take that person aside or, say, hey, you doing all right? Looks like you might need a little help. Is there a tough patient that you're working on? Something that you feel like you need some help working through? And so we try to lean on each other as a way to minimize that burnout. And so recognizing it and addressing it as a team. And if that isn't enough, then there are additional resources that we are aware of that we can try and pair those clinicians with.
Much less burnout in dermatology.
Yes?
Do you work with the same team for all of your patients or most of your patients?
Yes. We have a core team, but we will also interface with the bedside nurses in the ICU or the NICU, which is the neonatal ICU, or with the oncology ward, or with the outpatient clinics. We'll work with social workers and child life specialists in all those different areas, but we have a team of all of those different providers that we work with on a daily basis that are specifically trained in palliative care. Yes?
I know that palliative care is its own specialty, but I've also heard people argue that all of medicine should be infused with the kind of values of palliative care, like as you have up there, to cure sometimes, to comfort others. So I just wanted to hear if you could comment on that. There's a little bit of a tension between the specialty of palliative care versus a more broad suite of these kind of values and approaches, orientations.
Amen. I absolutely think that palliative care principles should be incorporated into every level of medicine. I think historically there was more day-to-day primary level palliative care practice as part of medicine, and as medicine has become more siloed and more technological in each individual specialty, and just incorporating more medical technology in the form of the medical record and